Good afternoon, Dr. Mukape. My name is Rogers Jaire, a fifth-year medical student, and today I would like to present a case on antepartum hemorrhage.
Go ahead, Rogers. Let's see what you've got.
The patient is a 32-year-old gravida 3, para 2 at 30 weeks gestation. She presented with painless vaginal bleeding that started about 12 hours ago. There was no preceding trauma, and fetal movements have been reported as absent.
Wait, Rogers, absent fetal movements, and you didn't seem alarmed by that? You're just going to casually mention it as if it's an afterthought? I hope you're not planning to deliver this baby next week.
Oh, I must have misspoken. I meant to say normal fetal movements.
Good save. Let's hope for the patient's sake you don't mix those up in real life. Carry on.
Right. The patient also has a history of hypertension in previous pregnancies, but there's no history of trauma or coitus before the bleeding.
So, based on this history, what's your provisional diagnosis?
Placental abruption because of her hypertension and the painless bleeding.
Placental abruption? With painless bleeding? Rogers, were you taking a nap in class? Abruptio placenta usually presents with painful bleeding. You know, like ouch, my abdomen is killing me. What you're describing sounds more like placenta previa. Try again.
Oh, yes, I see now. The painless bleeding suggests placenta previa, not abruption. That would be my provisional diagnosis.
Ah, now you're thinking. Maybe next time you'll get it right the first time. What else could it be?
Differentials. I would also consider vasa previa, because it causes painless vaginal bleeding.
Vasoprevia? Really? Are you just throwing out any term with the word previa in it now? This patient is 30 weeks pregnant, and you're thinking of a condition that usually presents during labor? What else, Rogers?
Cervical trauma or vaginal infection.
Finally, something reasonable. Just make sure you're not randomly picking conditions out of thin air next time. What about placental abruption as a differential?
Well, it's less likely due to the lack of pain, but still possible.
Yes, that's the correct answer. Without the wild guesses. Now, tell me about the examination.
The patient was hemodynamically stable. Blood pressure was 128ths of a millimeter of mercury, and pulse rate was 90 bpm. The abdomen was soft and non-tender, and the fundal height matched the gestational age. The fetal heart rate was 140 bpm.
And?
The ultrasound showed a low-lying placenta, which is consistent with placenta previa. There was no sign of retroplacental clot.
Well, you finally seem to be getting the hang of it. So, what's your diagnosis now?
Placenta previa, for sure.
For sure. No hesitation now, huh? I like the confidence, but keep an open mind, my friend. Concealed abruption is sneaky. Just because there's no pain or clot visible doesn't mean it's completely out of the picture.
Right. Concealed abruption is still possible.
Good. Now, let's talk management. What's your brilliant plan?
First, I'd do a vaginal examination to check for trauma.
Oh my goodness. A vaginal examination with suspected placenta previa? What are you trying to do? Turn this into a hemorrhage disaster right in front of your eyes? No vaginal exams unless you're sure it's not placenta previa. Ever heard of an ultrasound?
Yes, I meant to say I would perform an ultrasound first to rule out placenta previa. I wouldn't do the vaginal exam unless it was ruled out.
I sure hope so. What's next?
I would secure 2 large bore IV lines for fluid resuscitation, and I would administer corticosteroids because the patient is only 30 weeks gestation. I'd also monitor fetal and maternal vitals.
Finally, something that makes sense. I'm impressed, Rogers. Well, a little bit, anyway. Just make sure the blood bank knows what's coming. You don't want to be that guy waiting for blood when the patient's in shock, do you?
No, definitely not. I'd arrange for blood products early.
Good. Now, define antepartum hemorrhage for me.
Antepartum hemorrhage is bleeding from the genital tract after 20 weeks of pregnancy until the birth of the baby.
20 weeks? Are we making up numbers now? In Zambia, it's after 28 weeks, Rogers. Don't forget where you're practicing. Laughs, but I'll give you partial credit for trying.
Ah, yes, after 28 weeks in Zambia. Got it.
What's the incidence?
It occurs in about 2 to 5% of pregnancies.
At least you can remember percentages, Rogers. Now tell me, what are the two main causes?
Placenta previa and placental abruption.
Oh, look at you. You got it right. I was expecting you to throw in vasa previa again. Laughs. Now let's move on to placenta previa. What are the risk factors?
Advanced maternal age, multiparity, previous cesarean section, previous placenta previa, smoking, and multiple pregnancies.
Amazing! Finally, some answers without hesitation. Maybe you're starting to believe in yourself. Now, how do you confirm the diagnosis?
Transvaginal ultrasound is the best method to locate the placenta.
Wow, look at you pulling out the right answers all of a sudden. You must have had a light bulb moment. Just don't forget MRI can help with more complex cases, like posterior placenta or accreta. What are the complications?
Maternal complications include hemorrhage, premature labor, and postpartum hemorrhage. Fetal complications include low birth weight, fetal distress, and intrauterine death.
Well, Rogers, it looks like you are starting to know what you're talking about. Just do me a favor. Next time, try not to almost kill the patient in the process of diagnosing them. Keep it up, and you'll get there.